which is a drug that takes away the need or the desire to continue with opiates. Our Suboxone program is a two-part program. One is the medication, and secondly, anyone who receives the medication is required to be in therapy, to have a therapy component. And that can be group or individual or both, depending on the assessed need of that client. The fourth program that we run in substance abuse related, is DUI. We do both the education and we do the therapy component of the DUI program. What are the holes in services for Eastridge? The holes in services for Eastridge are the holes in services for the Eastern Panhandle. I don't claim title to what I'm about to talk about. We do not have a dedicated detox program, although Dan's unit does do detox by default. You're caught in that situation and have no choice. But we have no dedicated detox program. In addition, we have no residential program. What I would like to see, and what I think most of the people at this table would like to see in the Eastern Panhandle, is a continuum of services for substance abusers, beginning with detox, moving to residential, moving to some form of outpatient care, whether it be intensive outpatient, once-a-week therapy, Suboxone, whatever. But that continuum is not here. It's hurting us. And unfortunately, it's expensive. The other hole, if you will, that I have right now is, for those of you who are familiar with the history of Eastridge,
I thought you gave a great history of how we got into this scenario in terms of the defunding of state hospital beds and deinstitutionalization. The money from that was supposed to follow patients into the community. That over the budgetary years has really not happened, and so I think there's a lot of problems and challenges for the people with persistent mental illness and developmental disabilities in maintaining themselves in the community. Behavioral Health Services is a program of the Shenandoah Valley Medical System, a federally qualified health center. So the kind of programs we have are focused on psychopharmacology and therapy patients. Unlike Eastridge, we do not provide a lot of intensive case management. About 80% of the psychiatric visits in this country are basically happening on people that have never been to a hospital, don't have a chronic, persistently disabling illness, but have depression, ADD, maybe some of the PTSD people, bipolar disorders that function independently, or for the most part do, and need a lesser level of support to get to appointments and basically follow through. So we provided in behavioral health about 25,000 visits with therapists or psychiatrists in 2012. The kind of programming that we're doing, we have a child and adult team so that we see children down to the age of 4. On our child team, we see any adult that walks in the door. If they need intensive case management, we usually refer them out to Eastridge because they have those kinds of systems in place and we don't have them. When we think about the mental health system in the area, the substance abuse issues have really been in focus. We participated in the governor's substance use task force, and really what was recommended is what Paul mentioned, is that we need a kind of center or campus where people who are motivated for detox in any particular moment, whether it's from prescription drugs or whether it's from hardcore drugs on the street or alcohol dependence, can actually access treatment in a now kind of manner, and that they can be referred and placed into either a detox bed, a 28-day recovery bed, that there can also be an extension of services where they would be allowed to have long-term recovery programming. That could be 6 months. I think that if some of you watched local programming where one of our youngsters who were addicted was picked up by a TV show and sent to, I think it was Georgia or North Carolina, and got to stay 6 months and really pulled her life together. I think it was probably funded by the TV program or the network, but I think understanding that people often need a significant change in their day-to-day environment in order to address all the issues that they didn't, all of the life skills that they didn't put together for all the years they were practicing an addictive lifestyle. And I think that lady ended up in the military and college, and it was a wonderful story, except for those of us who are in the treatment system here recognize that those services don't really exist locally, that there isn't funding for long-term anything, but if we really want to make a dent in the addictive culture in our country, we have to begin to address both the access issue, which is people need help when they walk in the door and are motivated to do it, and then they need to have a recovery-related bed somewhere in order to continue to make progress and learn life skills and coping skills before they're sent back into their own environment. I mean, that just has been repeatedly stated in the research that the longer a person's involved in a recovery activities, the better quality and longer abstinence they have. So that's something that we're investing a lot in. We are currently participating in a grant from the state, which is for drug-free moms and babies, so that a lot of our substance abuse team resources are focused on dealing with pregnant addicts. This program has been very popular. It's a very expensive program. It includes transportation, outreach for 2 years, so that you not only see them through the pregnancy, you follow them up with a recovery coach, in-home visits for another 18 months post-delivery to ensure abstinence. So that's one element of what we do. We also have a Suboxone program. A lot of those pregnant women are involved in it, but we partner with one of our family practitioners, and one of our psychiatrists, Dr. Deal, provides Suboxone management so that we can kind of come together to monitor those folks. That is a very regulated kind of program, so that, for example, Medicaid folks have to be seen weekly. Less regulated than a methadone clinic where they have to go daily to pick up their methadone, but it is very highly regulated, and so there are a lot of compliance issues for people who don't come or have difficulty coming, that they are then no longer eligible for the med. So those programs come with some requirements, and they're also offered in a lot of non-psychiatric or mental health settings. There's some family practitioners throughout the community that offer those services, and I assume are contracting out the therapy piece. Other programs that we provide are therapy. We have a number of different therapists on staff, 3 psychiatrists. We provide crisis intervention to our primary care providers that are in the facility on a Monday through Friday basis in any event. And I think that the concerns we have for the community really is that behavioral health has had waiting list issues for a while. Any of you here that have tried referring to us know that you don't get in right away. Our waiting list average is about 300. And for the first time in a while, we've gotten it down to like 280, so we're very excited to be under 300. A child weighs, depending on age, so the under 10s, I would say, probably wait 3 months for an appointment. Part of that is that the child team really sustains therapy and family systems work with those targeted kids over a long period of time. So the turnover rate or completion of therapy when you're dealing with the child is much longer. If you think that you're also working with their care providers, their family members, either to how to respond to their special needs or if they have challenges of their own, that you can multiply the time by 3. And that's probably the difference in the turnaround rate or the availability for us to take in new cases as compared to an adult client. So adult clients wait 2 to 3 weeks for an appointment. If we have people out or something going on staff-wise, that may be a month, but generally that is the case. Shenandoah, as a federally qualified health center, provides the medical home model. So if we see people who need primary care or pediatrics, we can refer them down the hall and coordinate their care. We offer a sliding fee schedule for those folks who qualify for sliding fee. Some of the times when you hear horror stories about people that it took forever to get in is related to the fact that their inability to bring in the proof of income required by the feds to be eligible for some of these programs. So it's, I know that the free clinic has some of those issues too, where people have to demonstrate the need. Just can't come in and say, hey, I'm indigent, help me. So that is something, though, that about a third of our behavioral health patients at this point are on sliding fee. We also take Governor's Task Force, and I think got partially funded, but for a county in the middle of the state. What we would really like to see is something in the Eastern Panhandle, the highest volume of people who utilize these kind of services are probably in and around the Berkeley County area, so I think that people could get there, families could participate in the treatment modalities. The other thing that keeps coming up in our behavioral health work groups is the wish for a child and adolescent rapid stabilization unit locally. So we have really to send out of state for it to be closed. The only West Virginia accepting medical assistance child program is Brookline. Again, if there's a bed open, people can go. But getting families down to Chestnut Ridge or to sometimes Ohio, Baltimore, in order to participate in treatment of a child or adolescent that has severe mental health or substance abuse issues is really a challenge for the community. So those substance abuse campus and a rapid stabilization child and adolescent behavioral health unit locally is something that has been identified year after year. One of the other things I would say is there's been a lot of recent interest in violence in the communities. A number of those, since we have legislative people here, a number of those individuals involved in these murder scenarios have had some kind of mental health history. Those are the kinds of individuals that may have received more treatment if the patient rights legislations were really redesigned.